Just as with all homeostatic ranges, blood pH is going to have certain parameters within which it needs to exist. The pH of the blood is right around 7.4, and the acid-base balance of our blood needs to exist within the parameters of 7.35 to 7.45. In the event that the pH of the blood goes below 7.35, we call that acidosis. And in the event that our blood pH goes above 7.45, we're going to call that alkalosis. Anything beyond 7.35 is when our blood is too acidic, and anything beyond 7.45 is when our blood is too basic. There are several mechanisms that we're going to see that will help to regulate our blood pH and keep it between these very narrow parameters. Buffer systems is one mechanism that's going to be extremely helpful for this. Hopefully we can remember from Anatomy and Physiology 1 that a buffer is a series of chemical reactions that helps to resist the change in pH. We have three separate buffer systems that we're going to see very shortly, and all of these buffer systems will work with the exhalation of carbon dioxide and also kidney excretion of hydrogen to help maintain the blood's pH. We can hopefully see here how the kidney's excretion of hydrogen ions will help to regulate pH as we're getting rid of the hydrogen ions that make substances acidic. By excreting more hydrogen ions, we're making the blood less acidic, and by retaining hydrogen ions, we're going to make our blood more acidic. This will also affect certain buffer systems that have hydrogen as their component. But we also see right here in the center that the exhalation of carbon dioxide will also help to regulate our body's pH. This is going to be specifically useful in the bicarbonate carbonic acid buffer system, as carbon dioxide is one of the components of that buffer system itself. We'll see shortly that as we void our body of excess carbon dioxide, that's going to push the buffer system in the direction away from hydrogen ions and bicarbonate. So as this indirectly gets rid of hydrogen ions, that's going to be another mechanism that helps us to regulate pH. Now our first of the three buffer systems is known as the protein buffer system. And we call this the protein buffer system because this utilizes the base structure of amino acids to either grab onto excess hydrogen ions in solution or release excess hydrogen ions in solution to help control the pH and keep it at 7.4. This is going to be the most common buffer system inside of the cell. Now, in order for us to grasp this system in its entirety, we must go back over the structure of amino acids. Now, I don't expect you all to be biochemists and know all of the amino acid structures and whatnot, but I do want you to understand that every amino acid has a carbon as a base, and it's going to have four specific groups. The amino group, which is the NH2, and the carboxyl group, which is the COOH group, are going to be the two important groups in this buffer system. All amino acids will also have a hydrogen ion, and they'll also have an R group, which refers to the side chain that makes up different amino acids. Each of the amino acids will have their own side chain, and it's not necessarily going to be relevant for the protein buffer system. We want to focus in on the amino group and the carboxyl group. In the event that blood pH goes too high and the blood is too basic, the amino acids of the protein buffer system can actually release the excess hydrogen on the side of this carboxyl group. By releasing that extra hydrogen, that's going to significantly decrease the pH back to normal. But on the other end of things, in the event that blood pH goes too low and we're too acidic, the amino group can actually grab onto an extra hydrogen and exist in this form. We must remember that pH is talking about hydrogens. The more hydrogen ions we have in the solution, the more acidic we are, and the lower the pH is. So in the event that our blood pH is too high or too low, the protein buffer system is the first of the three that will help to keep blood's pH between 7.35 and 7.45. Now our second buffer system is what's known as the carbonic acid bicarbonate buffer system, and this is likely the one that you would have discussed in Anatomy and Physiology 1. In the event that you didn't or you don't remember, this buffer system utilizes bicarbonate to bind with hydrogen ions to form another chemical known as carbonic acid. But the buffer system doesn't stop there. Once carbonic acid is formed, it can also dissociate into carbon dioxide and water. And carbon dioxide is going to be the element that we can excrete from the lungs. So excretion of CO2 is directly linked to this buffer system. What we want to notice here is these arrows that are pointing in opposite directions are indicating that this reaction is in equilibrium. That means that there's an equal amount of these substances as there are this substance, and an equal number of this substance as there are these substances. In the event that we significantly decrease one of these substituents or increase one of these substituents, that's going to force the reaction in the direction away from the substance that is increased and to the substance that is decreased. If the blood's pH goes down, that means that there are more hydrogen ions in the solution, so hydrogen ion concentration is going to go up. In the event that hydrogen ion concentration goes up, that's going to lead to more reaction with bicarbonate, and that will form more carbonic acid. But as more carbonic acid forms, carbonic acid is going to dissociate into carbon dioxide and water, and these substances are going to be much more manageable, and as I mentioned, we can get rid of carbon dioxide through the respiratory system. So what we want to understand is that as hydrogen ion concentration goes up, that's going to form more carbon dioxide and more water, and then we can excrete that carbon dioxide through the lungs. So what we hopefully will understand is that as we get rid of carbon dioxide, that's going to force the reaction towards the left, causing more hydrogen to bind to bicarbonate, getting rid of this very, very strong acid. We also need to be careful of this, as when carbon dioxide concentration goes up, that's going to force this reaction to the right side, and that will form more hydrogen ions, making the blood more acidic. So we will come to see that hydrogen ions and bicarbonate can either be retained or secreted by the kidneys, and so that's one way we can control the amount of these substances in the bloodstream. But carbon dioxide is also able to be controlled by the respiratory system additionally. We can see that this feedback loop is demonstrating this process. In the event that there's a decrease in blood pH, that really means that there's an increase in the hydrogen ion concentration. Chemoreceptors in both the medulla as well as in the aortic and carotid bodies, in our large vessels, are going to be sensing the increased hydrogen concentrations that are in the bloodstream. These are going to send nerve signals up to the respiratory controllers in the medulla, and then the medulla is going to send signals down to the diaphragm to contract more forcefully and also to contract more frequently. The reason that we do this is to increase ventilation so that we get rid of excess carbon dioxide. As more carbon dioxide is exhaled, that's going to force substances towards the left side of the bicarbonate buffer system. It's going to form more water and also take hydrogen ions out of the blood. Removing hydrogen ions will eventually lead to the blood pH, restoring this controlled condition back to normal. Our final buffer system is the phosphate buffer system, and this is simply going to use two compounds known as dihydrogen phosphate as well as monohydrogen phosphate. I know the names on these are quite large, but we just want to keep in mind that dihydrogen phosphate has two hydrogens and monohydrogen phosphate has one hydrogen. Dihydrogen phosphate will bind to hydroxide ions to form water and monohydrogen phosphate. We'll hopefully remember that hydroxide is on the other end of the pH scale. Generally, we think of the pH scale in terms of hydrogen, and the more hydrogen ions there are, the lower the pH is. But in all reality, we can view the pH scale in terms of hydroxide ions as well. Hydroxide ions are what make substances basic. The more hydroxide ions there are in solution, that's going to mean that our solution is more basic. So on the other end of the pH scale, the phosphate buffer system will be present to bind to excess hydroxide ions to form monohydrogen phosphate and water. We know that the kidneys are very important in excreting certain substances from the blood, and hydrogen is one of the substances that the kidneys are going to be responsible for. By excreting more hydrogen into the nephron, we're going to help to regulate our acid-base balance by directly getting rid of the substance that's making our blood acidic in the first place. These actions will primarily be controlled by the proximal convoluted tubules as well as in the collecting ducts. So the three mechanisms that regulate pH in the body are buffer systems, exhalation of carbon dioxide, and the kidneys. We have three buffer systems as we've seen. We have the protein buffer system, the carbonic acid bicarbonate buffer system, and the phosphate buffer system. Both the exhalation of carbon dioxide and excretion of hydrogen ions by the kidneys are going to be linked to the carbonic acid bicarbonate buffer system. But one other way we actually will see the kidneys linked is that these will also be responsible for reabsorbing bicarbonate into the bloodstream. By retaining bicarbonate, that's going to increase our blood concentrations, and that's going to allow for more reactions with free hydrogens. That pushes substances towards carbon dioxide and water, and we've already now seen how the body gets rid of excess carbon dioxide. Excreting more CO2 with forceful contraction of the diaphragm is going to increase pH in the event that pH has dropped too low. We'll find the carbonic acid bicarbonate buffer system primarily in the extracellular fluid, and we find the protein buffer system most abundant inside of our body cells as well as inside of the blood. Now, we've seen some mechanisms to help regulate pH, but we also must understand that sometimes these buffer systems and other mechanisms can become overwhelmed, and it is possible for blood pH to go below 7.35 and above 7.45. As I mentioned, we call this acidosis, and we're going to call this alkalosis. Now, what's actually rather interesting is that acidosis and alkalosis exist in two forms. We have a respiratory acidosis and respiratory alkalosis, and we're going to have metabolic acidosis and metabolic alkalosis. While both respiratory acidosis and metabolic acidosis refer to a decreased pH below 7.35, it is the cause of each of these different types of acidosis that's going to differ. Respiratory acidosis and respiratory alkalosis are directly linked to carbon dioxide levels. If there's an increase in our body's carbon dioxide concentrations, that's going to lead to respiratory acidosis, and if there's a decrease in carbon dioxide, that's going to lead to respiratory alkalosis. On the other hand here, we see that metabolic acidosis and metabolic alkalosis are directly linked to our bicarbonate ions. If the amount of bicarbonate in our blood decreases, that leaves less bicarbonate present to bind to those hydrogen ions. That leaves more hydrogen ions in the blood, and therefore we've got metabolic acidosis. While over here, if bicarbonate concentrations go up too much, that can lead to metabolic alkalosis. So truly, it's our carbon dioxide levels that are going to relate to respiratory acidosis and respiratory alkalosis, and it's our bicarbonate levels that are going to indicate metabolic acidosis as well as metabolic alkalosis. We'll see on the next couple slides information comparing the respiratory acidosis and alkalosis to metabolic acidosis and alkalosis. First and foremost, respiratory acidosis, as I mentioned, it refers to an increased level in carbon dioxide. We say that the increased partial pressure of carbon dioxide is going to be the definition of respiratory acidosis. But thinking back to the respiratory system, carbon dioxide's partial pressure simply means increased carbon dioxide. All gases in a solution exert their own pressure as if no other gases are present. So increased partial pressure of carbon dioxide simply means that we've increased carbon dioxide concentrations. We've seen how increasing carbon dioxide will push the bicarbonate carbonic acid buffer system to the right, and that's going to lead to a decrease in pH as more hydrogen ions are present. Realistically, this can be caused by many things. Hypoventilation is one common cause of respiratory acidosis. We're not exhaling as much CO2 as we're supposed to. So hypoventilation in general can lead to respiratory acidosis. Emphysema, pulmonary edema, trauma to our respiratory system, or airway obstructions can all lead to an increase in the carbon dioxide concentrations. On the other hand, respiratory alkalosis is the opposite. Decreased partial pressure of carbon dioxide indicates that there's less carbon dioxide in the blood than there's supposed to be. This is going to manifest as an increased pH, and generally can be caused by the opposite conditions that led to respiratory acidosis. So hyperventilation, cerebrovascular accidents, or severe anxiety can all lead to respiratory alkalosis. In the event that we are hyperventilating, we're going to be excreting more CO2 than is necessary. That's going to increase our carbon dioxide concentrations as the bicarbonate buffer system will now move towards the left. So what's actually quite interesting about respiratory acidosis and respiratory alkalosis is that even though it is the levels of carbon dioxide that are going to indicate these two conditions, we're actually going to have compensatory mechanisms that come from the kidneys. The kidneys are what are going to be responsible for restoring these conditions back to normal. You can see the compensatory mechanism for respiratory acidosis is to increase the excretion of hydrogen ions. We already are undergoing acidosis, so by getting rid of more hydrogen ions, that's going to eventually lead in the increase in pH. But at the same time, the kidneys are also going to reabsorb bicarbonate ions. And we'll see here that with respiratory alkalosis, we're going to have exactly the opposite compensatory mechanism. We're going to decrease the excretion of hydrogen ions to lower the pH back to normal, and we're going to decrease the reabsorption of bicarbonate, which simply means that we're going to get rid of more bicarbonate. The compensatory mechanism for respiratory alkalosis is, of course, the opposite of the compensatory mechanism for respiratory acidosis. But what we especially want to keep in mind here is that respiratory acidosis and alkalosis that deal with carbon dioxide are going to have renal compensatory mechanisms that utilize hydrogen and bicarbonate. Metabolic acidosis and metabolic alkalosis are going to be different. Metabolic acidosis and metabolic alkalosis are going to refer to our bicarbonate levels. Metabolic acidosis refers to decreased bicarbonate, and metabolic alkalosis refers to increased bicarbonate. Again, we want to think about bicarbonate in the way that it's going to affect pH. If we don't have enough bicarbonate, there's going to be more hydrogen ions in the solution. While on the other hand, if we have too much bicarbonate, there's not going to be enough hydrogen ions in the solution. So the decreased pH of metabolic acidosis is generally caused by a loss of bicarbonate in the digestive system or in the kidneys, or perhaps the accumulation of acids for some other reason. If we're not reabsorbing as much bicarbonate as we need, this can lead to metabolic acidosis. But the increased pH that's caused by metabolic alkalosis can often be related to vomiting, diuretics, or very, very basic drugs. So as we're dealing with the dysfunction relating to bicarbonate, we're actually going to see respiratory compensatory mechanisms that are going to help to bring these back to normal. Here, with metabolic acidosis, the respiratory compensatory mechanism is hyperventilation. By increasing our ventilation rate, we're going to get rid of more CO2, and that's going to push the bicarbonate carbonic acid buffer system towards the left side of the reaction. Excess hydrogen will be used to help form carbonic acid, and we're going to have less hydrogen ions in the solution. The compensatory mechanism for metabolic alkalosis will also be respiratory, and that's going to be the opposite of what we saw up here. Hypoventilation is going to decrease the loss of carbon dioxide. This prevents the bicarbonate carbonic acid buffer system from moving to the left side, keeping it towards the right side. This helps to decrease pH and help restore this controlled condition back to normal. So in summary, what we want to keep in mind is that respiratory acidosis and respiratory alkalosis are going to have renal compensatory mechanisms, and metabolic acidosis and metabolic alkalosis are going to have respiratory compensatory mechanisms. Think of this considering that the component that's leading to the increased or decreased pH will need an outside mechanism to come in to help bring it back to normal. Now the last major concept that we're going to discuss here in chapter 27 are the differences between adults and infants in acid-base balance, fluid distribution, and overall homeostasis. One of the major differences that we see between adults and infants is that infants will have much more of their body mass that's actually made up of fluids. Infant bodies will contain about 75% fluids, and premature infants can contain up to 90% of body fluids. And what we found with adults is that 2/3 of all of our body fluids can be found in the intracellular fluids. Infants are going to be a little bit different. In fact, the intracellular fluid-extracellular fluid ratio is going to be reversed. Infants will have about 2/3 of their body fluids on the outside of their cells in the extracellular fluids. So in the events that infants are losing fluids, they're going to be much more susceptible to damage than adults will be. A couple of these differences that affect the distribution are shown down here. Infants will have a much higher metabolic rate than adults will. This indicates that more waste products will be produced by metabolism in the infant, which makes infants much more likely to develop acidosis. We also consider how developed the kidneys are, and in infants, the kidneys are not nearly as effective as they are in adults. Body surface area in general is going to be much greater in adults. However, considering total body mass, infants have a much higher surface area compared to their total body mass than adults will. This means that water loss through the skin is going to be much higher in infants than it will be in adults. Infants will also have a much higher breathing rate, which causes them to lose more water through ventilation. And based on the ionic concentrations that we find in infants, this also is going to make them a little bit more likely to develop acidosis as well. So all things mentioned, it's very important that the fluid, electrolyte, and acid-base balance of infants is carefully regulated, as they're much more susceptible to acquiring acidosis and developing damage. On the other end of life, older adults are also going to have much more challenging times regulating their fluid, electrolyte, and acid-base balance. Dehydration and acidosis become much more likely as we get older. Hypernatremia, referring to too much sodium, and hypokalemia, referring to deficiencies of potassium, are also two things that we see much more often in older adults. So these are two words that I don't expect you to have heard before, but by the end of this presentation, I want you to have a good grasp on the terminology used to name these terms. Hyponatremia and hypernatremia are referring to decreased and increased levels of sodium in the blood. We can use our understanding of anatomical terminology to deduce this. Hyper means increased, emia means the blood, and Na is depicting our chemical formula for sodium. Hyponatremia is referring to low sodium levels in the blood, and again this is going to use the same convention as we did over here. Decreased chloride levels in the blood is hypochloremia, and increased levels of chloride in the blood is hyperchloremia. As we just saw, hypokalemia refers to potassium levels, and this is also going to use the chemical symbol of potassium. Hyperkalemia refers to increased potassium in the blood, and we can also see the same convention used here with calcium, with hypocalcemia and hypercalcemia, phosphate with hypophosphatemia and hyperphosphatemia, and magnesium with hypomagnesemia and hypermagnesemia. From these last slides, I just want you to get an idea of what each of these conditions refers to, and I want you to be able to define them based on the anatomical terminology. That will conclude our presentation on Chapter 27 and fluid, electrolyte, and acid-base balance. If you have any questions, be sure to reach out, and I will see you all in our next chapter, Chapter 28, where we will start covering the reproductive systems.